listening with care, examining with precision, reporting with integrity.
That is a really powerful way to open our discussion today.
Yeah, I wanted to start with that centering statement because, well, few areas of forensic medicine demand greater sensitivity, technical skill, and ethical clarity than the examination of sexual assault and genitoanal injury.
Absolutely. Because when a patient presents following an allegation of sexual assault, the practitioner stepping into that clinical space carries this really profound dual responsibility.
Right, you're there for the medical care, but also as a documentarian.
Exactly. You provide immediate trauma-informed medical care and prophylaxis. But simultaneously, you have to step into the role of an objective, independent documentarian for the justice system.
Which requires a fundamental shift, from a purely therapeutic mindset to one that marries your clinical acumen with rigorous forensic discipline.
It's a unique and, frankly, highly challenging space to occupy.
Which is exactly why we are dedicating this entire deep dive to building out that conceptual framework for you.
Right. Whether you are a medical student prepping for your forensic exams, a junior doctor revising medical legal principles for an upcoming emergency medicine rotation, or even as a senior clinician revisiting these foundations.
This analysis is custom-tailored for you. We're going to structure your clinical thinking around the real-world realities of these presentations.
But we should state clearly right at the outset that this audio deep dive is a companion to, no, not a replacement for, reading Chapter 17 of Simpson's Forensic Medicine.
Yeah, that's crucial. We are going to mirror the structural flow of that chapter exactly. We'll emphasize the critical differentiations and the pattern recognition you need to make the text exam ready and clinically memorable.
But you definitely still have to engage with the textbook, the nuances of the clinical body diagrams, the exact phrasing required on forensic proformas, and the visual identification of specific trauma patterns.
You just can't get that without dedicated visual study of the text. So, our mission today covers the core themes of that chapter. We'll explore trauma-informed forensic examination, the strict legal definitions regarding sexual offenses, the art of the medical assessment, and forensic history taking.
Plus the rigorous protocols for evidence collection, interpretation of medical findings, and we will conclude with the critical clinical and legal considerations surrounding FGM or female genital mutilation.
But before we even dig into the epidemiology, there's one foundational medico-legal concept we really need to anchor this entire deep dive on.
Yes, and if you take away only one principle from this entire deep dive, it is this. Absence of injury does not mean absence of assault.
I want to repeat that because it's so vital. Absence of injury does not mean absence of assault.
It is a vital clinical and legal truth. Your role as a practitioner is objective documentation to support the justice process.
It is never your role to determine guilt.
Right. Nor is it your role to decide if an assault actually occurred based solely on the presence or absence of a mucosal laceration or a contusion.
Which, that requires a pretty significant paradigm shift for clinicians. We are trained in a traditional medical model where pathology typically equals diagnosis.
And in the forensic realm, the lack of physical pathology is just a completely neutral finding. It doesn't prove or disprove anything.
Okay, so with that core principle established, let's look at how Simpson's contextualizes the statistical reality of sexual assault.
The text uses the 2017 data for England and Wales to establish a baseline, and it's a sobering baseline.
Yeah, the estimates show that 20% of women, which translates to roughly 3.4 million individuals,
and 4% of men, so about 631,000 individuals,
have experienced some form of sexual assault since the age of 16.
But what really demands our attention clinically is the profound reporting gap embedded right inside those statistics.
The reporting gap is massive. The data indicates that around 5 in 6 victims, roughly 83%, do not report their experiences to the police.
So given that massive discrepancy, we have to think about how clinicians should interpret the frequently reported news headlines that say recorded sexual offenses are rising.
Right, because a superficial reading might lead you to assume there's an acute epidemic of new crimes happening right now.
But the analysis within forensic medicine suggests this increase is primarily driven by systemic changes, not necessarily a sudden spike in incidence.
We're seeing improvements in recording practices by authorities, for one.
And more significantly, a much greater willingness of victims to actually come forward.
Crucially, this includes non-recent victims.
Exactly. Individuals who were assaulted years or decades ago, who now feel that the societal and legal infrastructure might finally support them.
The text also does a really good job addressing intersectionality. It makes it clear that while anyone can be a victim, certain demographics face statistically varied odds.
It completely shatters the stereotype of a singular typical victim profile.
Right, the data reveals that transgender people and cisgender women have higher odds of sexual assault compared to cisgender men.
But the nuances are critical for your clinical awareness. Cisgender gay and lesbian individuals face higher odds of sexual assault than heterosexuals for men.
Though the cited study notes this isn't necessarily the case for women.
Right. And furthermore, bisexual individuals and those who are unsure of their sexual identity face significantly higher odds compared to their heterosexual peers.
With those effects often being more pronounced among cisgender men?
Which naturally transitions us into the context where a vast amount of physical and sexual violence occurs.
Intimate partner violence, or IPV. The World Health Organization data cited in the text presents a really grim global picture.
The WHO perspective is deeply concerning. They estimate that between 10% and 69% of women globally report being physically assaulted by an intimate partner during their lifetime.
From a clinical perspective, we know that individuals targeted by physical aggression within intimate relationships generally experience multiple acts of aggression over time.
It is rarely an isolated presentation in the emergency department.
So when you are formulating a risk assessment, particularly if you're a senior clinician managing safeguarding concerns, how does the UK data structure the risk factors associated with abusers?
The text groups these risk factors into a biopsychosocial framework. It's excellent for memory retention and structuring your clinical approach.
Let's break that down, starting at the individual level.
At the individual level, factors associated with a higher risk for abusing a partner include young age, heavy alcohol consumption, depression, and underlying personality disorders.
Also, low academic achievement, low income, and a personal history of witnessing or experiencing violence during childhood.
Moving outward from the individual, we look at the relationship level. Risk increases with marital conflict or instability.
Also, dynamics of male dominance within the family unit, economic stress, and just overall poor family functioning.
Finally, at the community and societal level, the risks are compounded by weak community sanctions against domestic violence.
Meaning the behavior is not socially ostracized in that community?
Right. Poverty, low social capital, and traditional gender norms or social structures that implicitly or explicitly support violence all contribute to the broader risk matrix.
Understanding these overlapping spheres is vital for any clinician who is raising safeguarding concerns.
Which brings us directly to the medico-legal framework. Specifically, Box 17.1 in Simpsons, detailing the Sexual Offences Act 2003 in England and Wales.
Now, a listener might be wondering why it's imperative for a clinician who is fundamentally a scientist and a healer to understand the precise legal wording of an act of parliament.
It is imperative because the exact wording of your physical examination findings must map seamlessly to the legal criteria without you making a legal judgment.
You are observing anatomy, mechanics, and biology.
Exactly. The court is tasked with establishing the legal definition. If your clinical notes are imprecise, or if you use colloquial legal terms incorrectly, you can inadvertently derail a legal proceeding.
Or misrepresent the patient's actual experience to the court.
Let us examine the anatomy of the act to really illustrate this. Let's look at Section 1, which covers rape. How is that strictly defined under this legislation?
Under Section 1 of the Sexual Offences Act 2003, a person commits the offense of rape if he intentionally penetrates the vagina, anus, or mouth of another person with his penis without consent and without reasonable belief of consent.
The operative anatomical requirement there is the penis.
Right. Now contrast that specific definition with Section 2, which covers assault by penetration.
Section 2 is defined as intentionally penetrating the vagina or anus of another person with a part of the body or anything else, meaning non-penile.
Where the penetration is sexual, without consent, and without reasonable belief of consent.
So the distinction between Section 1 and Section 2 relies entirely on the implement used. Penis versus digits, inanimate objects, or other body parts.
It's also really notable that Section 2 does not include the mouth in its anatomical scope.
That strict distinction underscores exactly why your medical history must capture precise details of what penetrated where.
Let's consider a clinical scenario to make this concrete. A patient reports to you that she was penetrated by a glass bottle.
If you write in your notes, patient reports she was raped, you have just utilized a legally inaccurate term based on the 2003 Act.
Because the legal definition of rape strictly requires a penis.
Exactly. Defense counsel will seize upon that discrepancy to question your precision, your competence, and the reliability of your entire forensic report.
Your duty is to document the mechanics verbatim. You write, patient states a glass bottle was inserted into her vagina.
That perfectly demonstrates the critical importance of utilizing neutral, descriptive language of the reported mechanics rather than applying legal labels.
What about Section 3 of the Act?
Section 3 covers sexual assault, which involves intentional sexual touching without consent and without reasonable belief of consent.
So this section covers acts that do not involve penetration.
Right. Understanding these strict boundaries dictates how your forensic swabbing and documentation are targeted. You have to align your clinical investigation directly with the specific allegations.
And understanding these strict legal burdens naturally raises the question of where and how we actually conduct these highly sensitive examinations. We have to ensure the recovered evidence meets those legal standards.
Which brings us to the vital role of sexual assault referral centers, or SARCs.
SARCs represent the absolute gold standard for post-assault care.
They are specialized, purpose-built facilities designed to provide an effective, sensitive, and entirely unbiased environment.
The overarching goal of a SARC is to optimize the identification and recovery of forensic trace evidence, while simultaneously prioritizing the psychological and physical well-being of the complainant.
The text highlights specific operational protocols within SARCs, like the importance of offering the complainant a doctor of their own sex or gender wherever possible.
That protocol is a fundamental tenet of trauma-informed care. The objective is to return a sense of agency, control, and safety to an individual who has just experienced a profound violation of bodily autonomy.
Providing an examiner of the requested gender is just a vital first step in rebuilding that trust within the clinical encounter.
The modern evolution of the SARC model also includes the provision of anonymized assessments. How does this specific pathway function clinically and legally?
Anonymized assessments address a huge barrier to evidence collection. A patient can present to a SARC immediately after an assault during the critical window when transient forensic trace evidence is still present.
We're talking about DNA or toxicology markers.
Right. The forensic clinicians can take the full history, perform the examination, recover the swabs, and securely store the evidence, entirely without the patient having to formally report the crime to the police at that exact moment.
Which acknowledges the reality that the immediate aftermath of an assault is rarely the optimal time for a traumatized individual to navigate a complex police investigation.
Precisely. It secures the transient evidence before it degrades. The patient is then afforded the time, whether that's days, weeks, or even months, to process the trauma.
They can access psychological support and decide on their own timeline whether they wish to proceed with formal police involvement.
And if they choose to report, the rigorously collected evidence is preserved and ready. If they choose not to, the evidence is eventually destroyed according to strict facility protocols.
It places the autonomy squarely back with the patient.
Now, regardless of whether a patient presents through an anonymized pathway or via a police referral, there is a fundamental hierarchy of care in forensic medicine.
The golden rule of priority.
The golden rule is unequivocal. Medical needs always override evidential needs.
Always. If a patient presents with a life-threatening hemorrhage from a vaginal or anal laceration, or they have a severe traumatic brain injury, urgent surgical repair and stabilization take absolute priority.
A clinician does not delay an urgent transfer to the operating theater to conduct a slow, meticulous forensic swab collection.
However, we should acknowledge that medical priority doesn't necessarily mean the forensic evidence is completely forfeited.
Right. Interdisciplinary coordination can salvage evidence in acute trauma scenarios. Forensic physicians or specially trained sexual offense examiners can actually be deployed directly to the operating theater.
While the patient is under anesthesia, and the trauma surgeons are actively managing the airway or preparing the surgical field.
The forensic clinician can rapidly take the necessary swabs, collect trace evidence, and document the injuries before the anatomy is surgically altered or heavily irrigated.
It requires immense communication and coordination between the trauma team and the forensic examiner.
Beyond acute surgical trauma, what does the comprehensive post-assault medical care and prophylaxis protocol actually involve within the SARC setting?
Post-assault care is a multifaceted intervention. It immediately addresses the risk of pregnancy with emergency contraception,
Offering either oral regimens or the rapid insertion of an intrauterine device, depending on the clinical timeline and, of course, patient preference.
Equally critical is the administration of prophylaxis for sexually transmitted infections.
The text specifically highlights the urgency surrounding HIV and hepatitis B post-exposure prophylaxis, or PP.
How does a clinician assess the risk profile to justify these specific interventions?
The decision to initiate HIV PP must be made rapidly, as efficacy drops significantly if it's delayed. It ideally needs to commence within 72 hours of the exposure.
The clinical risk assessment for viral transmission is quite complex.
The risks compound based on multiple variables. Were there multiple assailants?
Yeah.
Is there a known history of intravenous drug use by the assailant?
Are there associated mucosal injuries, such as tears or fissures, that significantly increase the likelihood of viral entry into the bloodstream?
And what is the baseline prevalence of these infections in that specific geographical demographic? All these factors dictate the prescribing regimens.
Which clinicians must continuously update based on the latest infectious disease guidelines.
Once the acute medical needs and prophylaxis are addressed, the clinician has to transition into the formal forensic assessment.
And this begins with trauma-informed consent.
We really need to unpack this. Why is the scope of consent in a forensic setting vastly more complex than consenting a patient for a standard hospital procedure?
Because the consent process, which is detailed in Figure 17.1 of the textbook, is not a static signature on a form. It is an ongoing, dynamic dialogue.
The complexity arises directly from the implications of the examination. The patient must explicitly consent with the clear understanding that the detailed report you write,
The scaled photographs you take,
and the intimate swabs you collect will likely be handed over to the police, scrutinized by defense lawyers, and presented as evidence in a court of law.
and the patient must understand their ongoing agency throughout that entire process.
Absolutely. You have to explain the use of chaperones, the exact nature of the instruments, such as the colposcope.
And critically, you must ensure the patient understands they possess the absolute right to halt the examination at any time for any reason without compromising their access to ongoing medical care.
Furthermore, regarding procedural integrity, the text emphasizes that separate examiners and entirely separate SARC facilities must be utilized for complainants and suspects involved in the same incident.
This is to eliminate the legal argument of cross-contamination.
Yes. If a clinician examines a complainant and subsequently walks down the hall to examine the suspect, even with rigorous hand-washing and complete changes of PPE,
Defense counsel will inevitably argue that the clinician inadvertently transferred trace DNA from the victim to the suspect.
and that argument can compromise the entire chain of evidence.
Yeah.
Complete physical and personnel separation is mandatory.
With consent established, the clinician takes the forensic history. The guiding maxim here is that the history directs the science.
I love that phrase. How does the specific narrative dictate the physical examination?
Every single detail of the patient's narrative maps to a specific physical action or swabbing site during the exam. A forensic clinician does not swab randomly.
As outlined in Figure 17.2, the questioning is incredibly specific. Was there kissing? Was there licking or biting?
If a patient discloses being bitten on the shoulder, that history directs the clinician to recover DNA from a dermal site completely outside the genitoanal region.
The history must also capture the specifics of the penetration and ejaculation.
Precisely. Was there ejaculation? If so, where did it occur? Was it internally, on the skin, on clothing?
Were weapons, restraints, or foreign objects utilized?
The answers to these highly specific questions create the exact roadmap for the examination and dictate which specific pre-packed forensic swabbing modules you are going to use.
To visualize the urgency of this process, we can use the metaphor of the degrading crime scene.
When an assault occurs, the patient's body is the primary scene of evidence.
But unlike a physical room that police can secure and lock down with tape, a living body is a dynamic, self-cleaning ecosystem.
That metaphor perfectly encapsulates the forensic challenge. It is why the clinician must meticulously document every single action the patient has taken after the assault.
Have they brushed their teeth or used mouthwash? Have they urinated, defecated, or wiped themselves?
Have they showered, douched, or bathed? Have they changed a tampon or a sanitary pad? Have they consumed food or drink?
Every one of those mundane, highly understandable actions actively degrades or destroys potential trace evidence.
If a patient brushed their teeth and consumed a hot beverage, the likelihood of recovering the assailant's cellular material from the oral cavity plummets.
It is crucial to emphasize that clinicians do not ask these questions to pass judgment or to suggest the patient did something wrong by washing.
Not at all. Seeking cleanliness after trauma is a profound and completely natural psychological response.
The clinician asks these questions so that when the forensic laboratory inevitably processes a negative oral swab, they have the necessary context.
The swab was not negative because the assault is a fabrication. It was negative because the enzymes in the beverage and the mechanical action of the toothbrush destroyed the trace DNA before collection was possible.
The history also mandates a sensitive but thorough inquiry regarding intoxicants, specifically the recent intake of drugs and alcohol.
This inquiry is purely about medical and legal context, never moral judgment.
Documenting intoxicant levels is vital to assess the patient's capacity to consent to the sexual activity at the time of the incident,
As well as their current clinical capacity to consent to the forensic examination itself.
and their ability to accurately recall sequential events. Furthermore, it explores the critical possibility of drug-facilitated sexual assault.
If a patient describes a sudden loss of memory, profound incapacitation after just a single drink, or waking up in an unfamiliar environment,
That clinical history immediately directs the clinician to secure early blood and urine samples for comprehensive toxicology screening.
which transitions our focus to the physical collection of those samples, evidential sampling, and the persistence of evidence.
How do standardized kits and chain of custody protocols protect the integrity of these samples?
Standardization is the absolute bedrock of forensic integrity. Clinicians utilize pre-packed, rigorously quality-controlled sample kits, which you can see illustrated in Figure 17.3 of the text.
The examiner must wear disposable barrier clothing, suits, double gloves, surgical masks, and hairnets.
The examination room itself undergoes intense pre- and post-examination cleaning protocols.
The objective is to absolutely eliminate any possibility of environmental contamination that could introduce stray DNA and compromise the forensic analysis.
Every sample is sealed, signed, and continuously tracked to maintain an unbroken chain of custody from the patient's body directly to the laboratory bench.
For the clinicians listening, understanding the persistence timelines of biological evidence is a critical competency.
The textbook provides specific parameters for the persistence of semen, which we can conceptualize as the 2-3-7 rule.
Let's break down how those timelines map anatomically. This is a highly testable area in forensic exams and just crucial for clinical triage.
How long can foreign biological fluids, specifically spermatozoa and seminal fluid, be reliably detected after an assault?
Let's start with the mouth. In the mouth, the maximum window is up to 48 hours or 2 days.
Moving to the anus or rectum, the window extends up to 3 days.
And in the vagina or endocervix, the window is the longest, persisting up to 7 days.
Hence the memory anchor, the 2-3-7 rule.
What are the underlying biological mechanisms that cause such a drastic variance in persistence times across these different mucosal environments?
It relates entirely to the biological hostility of the specific anatomical environment.
The oral cavity is highly hostile to foreign DNA. It is subjected to constant salivary flow, digestive enzymes like salivary amylase,
And the mechanical shear forces of eating, drinking, and talking. Evidence degrades extraordinarily rapidly there.
The anal canal presents a different kind of hostile environment. It contains fecal matter, dense bacterial flora, and the mechanical forces associated with bowel movements.
Conversely, the vaginal vault, and particularly the sheltered crypts of the endocervix, can provide a relatively protected environment.
Allowing cellular material and spermatozoa to persist for significantly longer, up to that 7-day threshold.
In clinical practice, what is the protocol if a patient presents near the end of those windows? Say, on day 6, and the history is slightly ambiguous regarding whether ejaculation actually occurred.
The overarching rule of thumb in forensic clinical practice is perfectly clear. If in doubt, take the sample and retain it.
A clinician can always consult with a forensic scientist or toxicologist after the fact to determine if laboratory analysis is viable based on the specific history.
However, if the clinician fails to take the swab during that clinical encounter, the physical opportunity to recover that evidence is permanently lost.
Table 17.1 in the text provides an excellent matrix mapping these various samples to their specific forensic findings. Let's examine a few of the critical connections.
The sampling strategy is comprehensive. Buccal scrapes are taken directly from the patient's inner cheek to establish their own baseline DNA profile.
This is essential for elimination purposes, allowing the lab to cleanly separate the victim's DNA from any foreign DNA found on the swabs.
Skin swabs, guided meticulously by the history of contact, aim to recover the assailant's saliva, epithelial cells, or trace lubricants.
Fingernail swabs and scrapings are also highly significant.
If the history indicates the victim fought back, scratched, or grabbed the assailant's epidermal cells or blood might be trapped beneath the nails.
And finally, early blood and urine samples are collected for toxicology and calculating back extrapolations of alcohol or drug levels.
This brings us to the interpretation of the physical examination itself, specifically the medical findings in injury interpretation.
And here, we must confront the core paradox of the genitoanal examination that we introduced at the very beginning of this deep dive.
The clinical paradox is profound and, honestly, often misunderstood by juries, law enforcement, and sometimes even untrained medical professionals.
It is widely yet incorrectly assumed that violent sexual assaults will inevitably result in visible traumatic injury to the victim's genitalia.
The objective clinical reality is that in the vast majority of cases involving both adult and pediatric populations, medical abnormalities and injuries will be completely absent.
Furthermore, if minor mucosal injuries are present, the high vascularity of the genital region means they heal incredibly quickly,
Often resolving completely within just a few days.
The critical differentiation that clinicians must articulate is that enthusiastic, consensual sexual activity can result in severe, highly visible injury.
Conversely, a brutal, non-consensual sexual assault can leave absolutely zero physical trace.
Therefore, the presence or absence of genital injury cannot be utilized to determine the legal question of consent.
That is the crux of the entire issue. A multitude of variables influence whether genital injury occurs.
The age and estrogen status of the patient, the specific type of sexual activity, the relative anatomical positions, the use of lubricants, and the degree of intoxication all play a massive role.
The text specifically notes that consensual digital penetration can easily cause accidental fingernail damage,
resulting in minor lacerations, abrasions, or erythema to the labia, the hymen, or the posterior fourchette.
Under colposcopic magnification, those specific tissue injuries look anatomically identical, regardless of whether the penetrating digit was welcome or forcefully imposed.
The mucosal tissue simply does not record the legal context of the trauma.
Because the genital findings are so frequently absent or ambiguous, the extragenital injuries become vital.
The findings on the broader canvas of the body often become the most critical medical evidence to corroborate an assault narrative.
Frequently, the most compelling corroborating medical evidence is located far away from the genitoanal region.
Forensic clinicians meticulously search for marks indicative of blunt contact, physical restraint, or coercion.
The textbook provides a vivid clinical example in Figure 17.5, illustrating fingertip or hand bruising localized on the inner aspect of the thighs.
These represent classic grip marks. They strongly corroborate a narrative where a victim was forcefully restrained and held open.
Another critical extragenital finding detailed in the text involves scleral hemorrhages and facial petechiae.
How does the pathophysiology of non-fatal strangulation produce these very specific markers?
These findings are critical red flags for non-fatal strangulation, which carries a remarkably high risk of subsequent mortality.
The pathophysiology is based on vascular anatomical pressures.
When an assailant's hands or a ligature compress the victim's neck, they typically occlude the jugular veins first.
Because the jugular veins are relatively superficial and low pressure.
Right, they occlude long before they apply enough force to compress the deeper high-pressure carotid arteries or the trachea.
This creates a severe vascular bottleneck.
Exactly. Arterial blood continues to be pumped upward into the head by the heart, but the venous blood cannot drain back down the neck.
This causes the hydrostatic pressure within the venous system of the head and face to skyrocket rapidly.
And that massive acute pressure causes the fragile capillaries in the face, the eyelids, and the conjunctiva to physically rupture.
This extravasation of blood leaves behind pinpoint red spots known as petechiae, or larger confluent scleral hemorrhages.
If a patient's history includes an assault, and the clinician observes those petechiae, it heavily corroborates a narrative of severe, life-threatening force.
Even if the subsequent genital examination is completely unremarkable.
Let us address the forensic interpretation of anal penetrative intercourse, an area that is frequently fraught with both societal misconceptions and clinical misinterpretations.
The clinical approach has to dismantle these misconceptions using objective pathology.
Consensual anal sex is a standard component of the sexual repertoire for a significant portion of the population across all sexual orientations.
When it is consensual, prepared for, and lubricated, it is generally pain-free and usually leaves no residual visible injury or anatomical distortion.
But the clinical corollary regarding non-consensual anal sex is equally important.
Non-consensual anal penetration, if it occurs without the use of extreme, rapid, blunt force.
And particularly if there is no physical resistance. For instance, if the victim is immobilized by fear, unconscious, or incapacitated by intoxicants.
It may also leave absolutely no residual physical injury. The sphincter can accommodate penetration without tearing under various circumstances.
So what are the specific pathological mechanics that do increase the likelihood of traumatic anal injury?
Traumatic injury is significantly more likely if the individual lacks prior experience with anal intercourse.
If there is a total absence of lubrication, if rapid, uncontrolled, or severe blunt force is utilized.
Or if there is a profound disparity in size between the anal sphincter, which has limited resting variability, and the penetrating object or penis.
When traumatic injuries do manifest, they typically present as localized contusions, mucosal fissures, submucosal hemorrhages, or frank tears.
However, due to the exceptional blood supply in the perianal region, if there is no repeated chronic trauma, these acute fissures heal remarkably fast.
Often resolving entirely within 2 weeks and frequently leaving absolutely no permanent scar tissue.
That rapid healing process, combined with the normal resting anatomy of the region, brings us to a major clinical pitfall.
The immense danger of medical mimics. Recognizing mimics is a critical competency for the forensic examiner.
You must possess the clinical experience to differentiate acute traumatic assault injuries from normal anatomical variants or underlying pre-existing medical conditions.
For instance, an anal fissure caused by chronic, severe constipation can present remarkably similarly to a superficial mucosal tear resulting from a recent assault.
Conditions such as threadworm, which causes intense nocturnal pruritus and subsequent secondary excoriation from the patient's scratching.
Poor perianal hygiene or active inflammatory bowel diseases like Crohn's disease.
All of these can create intense erythema, microlacerations, and tissue friability that closely mimic traumatic injury.
Misclassifying a medical condition as trauma can have absolutely devastating legal consequences.
Managing this clinical ambiguity relies entirely on the clinician's documentation discipline. How must a forensic report be structured to maintain absolute objectivity?
The documentation must be fiercely neutral, purely descriptive, and completely devoid of interpretive bias.
Clinicians utilize detailed, standardized body diagrams.
They utilize tools like colposcopes to provide standardized magnification and illumination.
They capture scaled, color-barred digital photography, which is subject to incredibly strict, secure viewing guidelines to protect the patient's dignity and ensure chain of evidence.
The golden rule of this documentation is describing what is seen, entirely separated from theories of how it happened.
Precisely. A disciplined clinician writes, observed a 2 mm superficial mucosal erythema at the 6 o'clock position on the posterior fourchette.
They absolutely do not write observed a 2 mm tear caused by forced penile entry.
The clinician's duty is to describe the objective physical reality.
The interpretation of how that specific erythema was generated is a matter for the court to decide, utilizing the clinician's objective findings as one component of a much larger evidentiary puzzle.
We are now shifting our focus to the final major topic covered in Chapter 17, which is a distinct but highly critical area of forensic medicine.
Female genital mutilation, or FGM.
How does the World Health Organization define this practice?
The WHO defines FGM as encompassing all procedures that involve the intentional, partial, or total removal of the external female genitalia.
Or other intentional injury to the female genital organs, specifically for non-medical reasons.
The global scale and the resulting human toll of this practice are staggering.
The textbook notes that there are over 200 million women and girls alive today who have been subjected to these procedures globally.
It is universally recognized as a severe human rights violation and a direct violation of the rights of the child.
Because the procedures are predominantly carried out on minors, ranging anywhere from infancy to age 15.
The health consequences are devastating and span a patient's entire lifespan.
Immediate acute risks include severe hemorrhage, neurogenic shock from immense pain, localized tissue infection, systemic septicemia, and death.
Long-term, these individuals face a lifetime of chronic pelvic pain, recurrent and severe urinary tract infections, and the formation of complex dermoid cysts.
There are also severe obstetric complications during childbirth and significantly increased risks of perinatal death for their infants.
For clinicians, accurately recognizing and classifying the specific type of FGM is paramount for guiding surgical or obstetric management.
The WHO provides a 4-part classification framework. How do types I through 4 progress in terms of anatomical alteration?
The classifications represent a progression of anatomical alteration. Let's start with type 1.
Type I is clinically referred to as clitoridectomy.
This involves the partial or total surgical removal of the clitoris and/or the prepuce.
Moving to type 2, which is known as excision, this is a more extensive alteration.
It involves the partial or total removal of the clitoris and the labia minora. This excision may occur with or without the concurrent excision of the labia majora.
Type 3 represents the most anatomically restrictive alteration, carrying the highest risk for severe, long-term urological and obstetric complications.
Yes, type 3 is clinically termed infibulation. This involves the deliberate, extensive narrowing of the vaginal orifice.
A covering seal is surgically created by cutting and appositioning the labia minora and/or the labia majora.
This fusion often leaves only a microscopic opening for the passage of urine and menstrual blood.
Type 3 procedures may or may not also involve the excision of the clitoris.
The obstetric management of type 3, requiring skilled deinfibulation prior to delivery, is highly complex.
Finally, what does type 4 encompass?
Type 4 serves as a comprehensive category for all other harmful procedures performed on the female genitalia for non-medical purposes that do not fit neatly into the first 3 categories.
This includes practices such as pricking, piercing, incising, scraping, and cauterizing the genital tissue.
Beyond the critical clinical recognition and medical management, there is a profound medico-legal duty associated with FGM, particularly within the jurisdiction of England and Wales.
How does the FGM Act 2003, as amended by the Serious Crime Act 2015, dictate clinical behavior?
This legislation created a strict, uncompromising mandatory reporting duty. It applies specifically to regulated healthcare professionals, social care professionals, and teachers.
You are legally mandated to make a formal report directly to the police under 2 very specific, distinct circumstances.
First, if a girl who is strictly under the age of 18 explicitly discloses to you that an act of FGM has been carried out on her.
Second, if you, during the normal course of your professional clinical duties, visually observe physical signs which appear to show that an act of FGM has been carried out on a girl under 18.
The crucial legal nuance in that legislation centers on the age of the patient at the time of the clinical encounter.
Yes, the legislative focus is aggressively targeted at the active safeguarding of minors.
The mandatory reporting duty to the police applies specifically and exclusively when the patient is under 18 at the time of the disclosure or the physical identification.
The mandate does not apply in the same automatic direct-to-police manner if an adult woman, someone currently over 18, discloses a historical procedure that was performed when she was a child.
In that historical disclosure scenario, standard adult safeguarding principles, psychological support pathways, and specialized clinic referrals apply.
But the automatic criminal police reporting mandate is specific to protecting minors who may still be at active risk or have siblings at risk.
Furthermore, the text heavily emphasizes that this reporting mandate is a personal duty. What are the clinical implications of that specific legal phrasing for a junior doctor?
It is a vital concept regarding professional liability. A personal duty means the legal obligation rests solely on the shoulders of the individual professional who heard the disclosure or observed the physical signs.
You cannot delegate this legal responsibility. You cannot simply notify the surgical consultant and assume they will handle it.
You cannot just document the finding in the electronic patient record and assume the safeguarding team will automatically generate a police report.
You, the individual clinician, must ensure the report to the police is physically made.
Importantly, the law explicitly protects the clinician, stating that complying with this mandatory duty does not constitute a breach of your professional medical confidentiality requirements.
That clarity is absolutely essential for navigating what are incredibly complex and highly charged clinical encounters.
We have covered a massive amount of dense conceptual ground today.
To ensure this information translates into clinical practice and exam readiness, we are moving to Section 8, our learning reinforcement.
Let's stress test these concepts for the clinicians listening. I will present a rapid-fire single best answer clinical prompt. We will pause briefly, and then the expert will provide the correct answer and the underlying rationale.
Ready when you are.
Prompt 1. Under the Sexual Offences Act 2003 in England and Wales, what specific anatomical feature legally differentiates the offense of rape under Section 1 from assault by penetration under Section 2? Pause.
The answer is the use of a penis. Section 1, rape, strictly requires intentional penetration utilizing a penis. Intentional sexual penetration utilizing digits, inanimate objects, or other body parts falls distinctly under Section 2, assault by penetration. If you need to refine this legal distinction, revisit the definitions and the laws section of Chapter 17.
Prompt 2. A complainant arrives at an emergency department disclosing a sexual assault. According to standard forensic biological guidelines, what is the maximum persistence time a clinician can expect to successfully detect seminal fluid or spermatozoa in the vaginal canal or endocervix? Pause.
The answer is up to 7 days. Recall the 237 rule regarding the persistence of biological evidence. It is 2 days for the oral cavity, 3 days for the anal mucosa, and a maximum of 7 days for the more sheltered vaginal or endocervical environment. For further review on the biology of evidence degradation, check the evidential sample section.
Prompt 3. During a thorough, magnified genitoanal examination of a patient complaining of assault, you observe superficial anal fissures. Name 2 common pre-existing medical conditions that can create tissue findings that mimic traumatic anal injury. Pause.
Acceptable answers include constipation-induced chronic fissures, threadworm causing secondary excoriation, poor perianal hygiene resulting in erythema, or active inflammatory bowel conditions such as Crohn's disease. Accurately differentiating traumatic injury from these medical mimics is a vital forensic skill. Revisit the medical findings after sexual contact section for more detailed differential diagnoses.
Prompt 4. A 16-year-old patient discloses to you during a consultation that she underwent a procedure in her home country involving the deliberate narrowing of her vaginal orifice with the creation of a covering seal. Which specific WHO FGM classification type does this anatomical alteration represent? Pause.
The answer is type 3, clinically known as infibulation. This is specifically defined by the narrowing of the orifice with a covering seal. Recall that type 1 is clitoridectomy and type 2 involves excision. Review the female genital mutilation section to solidify these structural classifications.
Prompt 5. You are a junior doctor working in a preoperative assessment clinic in England. A 15-year-old girl is admitted for an appendectomy. During routine pre-op catheterization, you observe clear, undeniable physical signs of FGM. To whom are you legally mandated to directly report this finding? Pause.
The answer is the police. Under the FGM Act 2003 and subsequent amendments, because the patient is strictly under 18 and you have personally observed the physical signs during your clinical duties, you hold a personal, non-transferable legal duty to report this finding to the police. You cannot delegate this to your senior registrar or consultant. Revisit the female genital mutilation section regarding the nuances of legal duties.
Prompt 6, our final clinical prompt. True or false, in forensic medicine, the severity of a visible genital injury directly correlates with the amount of physical force used in a non-consensual sexual assault. Pause.
The answer is a definitive false. Severe genital injury can easily occur during enthusiastic, consensual sexual activity, and absolutely zero physical injury can be found following a violent, non-consensual assault. The presence, absence, or severity of injury cannot determine the legal issue of consent. This is the core paradox outlined extensively in the medical findings section.
If you stumbled on any of the nuances in those prompts, you know exactly which sections of Simpson's Chapter 17 require a second pass.
As we conclude this deep dive, I want to leave you with a final thought regarding the intersection of clinical medicine and the justice system.
We spend immense time learning the mechanics, the optimal swabbing technique, the proper adjustment of the colposcope, the legal definitions of assault.
But the most powerful tool a clinician brings to a sexual assault examination isn't a piece of specialized equipment.
It is their objective, disciplined documentation deployed alongside profound human compassion.
We document the physical reality of the body so that the justice system can attempt to address the moral and legal reality of the act.
The question I want you to consider is this. If this highly structured, trauma-informed approach, where we engage in ongoing consent, where we explicitly explain every physical touch before it happens, where we prioritize the patient's immediate psychological safety over our own procedural efficiency.
If that works so effectively in the intense, high-stakes environment of a SARC,
how might our broader healthcare systems evolve if we integrated this exact same trauma-informed approach across all general medical encounters?
what if every routine physical exam, on every general medical ward was conducted with that identical level of rigorous respect for bodily autonomy.
It is a vital consideration. It takes a specialized forensic principle and proposes it as a universal standard for all clinical care.
To our listeners, thank you for joining us for this analysis.
I remind you once again to engage directly with Chapter 17 of Simpson's Forensic Medicine to solidify these conceptual frameworks. Use this audio deep dive as your structural guide as you read the text.
Continue your journey toward practicing medicine with precision.
Reporting with unyielding integrity, and above all, listening to your patients with care.